adolescent suicide and prevention, due to which we are losing so many youngsters at the budding stage. And we must know that we are losing one student every hour in India. So, as pediatricians, we should be aware of this fact, and whatever small role we will be able to do, we have to do as gatekeepers. So, suicide is often a permanent solution by ending life for a temporary problem, but not a trivial problem. It is a way to escape from psychological pain, which is usually acute or prolonged. So, if the crisis is managed properly, many deaths can be prevented. The situational analysis says that India has one of the world's highest suicide rates from age 15 to 29. One student commits suicide every hour. 40% of them occurs in less than 30 years. Many suicides go unreported as some other deaths. So, suicide is the third leading cause of adolescent mortality. So, the crux of the problem is 35.5 per 1 lakh population is the incidence. Many young people commit suicide in South India than anywhere else in the world. Karnataka, Tamil Nadu, Andhra Pradesh, Telangana, West Bengal and Tripura have high suicide death rates for both men and women. But for men, it is Kerala and Chhattisgarh. Suicides are common when the exam results are announced. 10th result, 12th result வந்த உடனே அடுத்த நாள் பேப்பர்ல மாணவன் தற்கொலை மாணவி தற்கொலை அப்படின்ட்டு. ஃபேமிலியல் ப்ராப்ளம்ஸ், வீட்டில் என்னை திட்டாங்க, என்னைய வஞ்சிட்டாங்க. அஃப்கோர்ஸ் இந்த பருவ வயதில் வரக்கூடிய இனக்கவர்ச்சியும் காதலும், love failure are the other common causes. You see here in this map, the developed states have higher suicide rates because this generation is becoming more familiar with the word stress. In our generation, we never used to know this word at all. இந்த வார்த்தையே நமக்கு தெரியாது. ஆனா இப்போ எதை கேட்டாலும் ஸ்ட்ரெஸ். So, the objective of this session will be to discuss the risk assessment of suicidal behavior in a primary care setting of pediatricians, to outline a safety management plan, to sensitize regarding preliminary counseling and partnering with psychiatrists. We know that pediatricians are often the first point of contact for adolescents and share excellent rapport with them and their families. So, pediatricians need guidelines to screen, assess, manage and prevent this suicidal behavior to ensure their survival, health and mental well-being of this vulnerable population. Poor health-seeking behavior of adolescents, we know that they don't come to the purview of the physician. Of course, in our country itself, only one psychiatrist is available for 1 lakh population. So, we have to step into their role and we must actually catch hold of them when the adolescents have mental health issues. So, we must know that suicide is a preventable cause of death. These suicides can be divided as completed attempts and para-suicides. This NSSI, we will deal it later. The rate of suicidal attempts is significantly higher. Rate of completed suicide increases from early to late adolescence. Boys have a higher incidence, 3:1. For every recorded suicide, there are 20 suicide attempts and 10% succeed. Men commonly use more lethal modes and plan the act more meticulously to avoid detection. So, suicidal behavior starts as an idea. It goes into the thought process and the intention comes out. Then they go for a plan and attempt and go for the ending their life. So 90% of suicidal attempts among adolescents are impulsive. We must know the difference between the impulsivity versus rationality of these young adults. Neurodevelopmentally, they are prone to impulsive, risky behavior, especially in stressful conditions. They have an immature prefrontal cortex that may impair judgment and control. They also have a highly reactive limbic system and reward center, which pushes them into this behavior positively or negatively. So, adolescents with suicidal thoughts can be classified into three risk groups. Low risk, for whom the thoughts of death only occur, but there is no plan or behavior. Moderate risk is the suicidal ideation with limited suicidal intent and no clear plan. High risk is these individuals who have a plan with preparatory behavior. They have acquired means to end their life. So warning suicide, signs of suicide, usually 4 out of 5 adolescents, they give the warning signs. We have to catch hold of them at that time. So they verbalize, like they say the death wish in a social media or to someone, like, I should have never been born here. I wish there was an end. They acquire means, say, like they collect weapons, ropes, pills, and they go for Google search for train timings to go in front of the train. They search for the internet. There is some, they say, have a feeling of hopelessness. There is no hope. Life has no meaning. ஒன்றும் இருந்து ஒன்றும் புண்ணியம் இல்லை, முடிச்சுக்கலாம் போல இருக்கு, இருக்கிறதே வேஸ்ட் அப்படிங்கிற மாதிரி. செல்ஃப் ஹேட்ரட், ஐ ஆம் அ பர்டன் டு மை ஃபேமிலி ஆர் திஸ் வேர்ல்ட். இந்த குடும்பத்துக்கு நான் பாரமா இருக்கேன், இந்த உலகத்துக்கே நான் பாரமா இருக்கேன் அப்படிங்கிறது. Getting things in order, they give away possessions, valuables to friends or siblings. They, in elderly, you can see closing bank account and doing charity. They will try to say goodbye by making unexpected visits to friends and relatives, and this is their form of saying bye bye from this world. So social withdrawal is isolation from friends and family, abnormal behavior, excessive anger and aggression. So high risk behaviors also come here: reckless driving, drug abuse, and over consumption of alcohol and tobacco. But what does the adolescent have? Which adolescents have these protective factors? Are the family, if it is stable, those are protective. When there is a religious involvement, positive connectedness with the school, good relations with the peers, ability to solve problems and to overcome adversity, absence of mental illness, access to mental health services, if at all, lack of access to lethal weapons. These are the protective factors, and the risk factors are a previous suicidal attempt, non-suicidal self-injury, psychiatric illness, family factors, family disruption, single parent, of course, disrupted families, school issues, bullying, substance abuse, sexual and physical abuse, gender identity disorder, inappropriate expectations from the parents or relatives or peers, influence from media. All, we must know the leading causes are, as I said earlier, familial problems, illness in older children, unemployment, love affairs. These are the percentage. Drug abuse, failure in examination, change in economic status, poverty and dowry dispute. We must know that adolescents with academic difficulties and learning problems have 3 times higher risk of suicide. The common methods used, as we see in our hospital setup, the most common cause is the poisoning. They try to consume எலி மருந்து அல்லது இந்த பூச்சி மருந்து. Hanging is another second leading cause, self-immolation, drowning and jumping from heights. We must know that not all persons who commit suicide want to die, and not all persons who want to die commit suicide. The myths about suicide, we must know, talking about suicide is a bad idea as it may encourage them to do it. No. When they talk about it, we must try to help them. Those who talk to it, They actually mean it. And those with mental illness only are suicidal. No. Impulsivity, I said, sudden impulse also, definitely they will go in for suicide. One suicidal, always so. No. When they recover, they definitely come out of these suicidal thoughts. Most suicides happen without warning. No, warning signs are definitely there. 4 out of 5 people give it. People who attempt suicides are weak. No. Suicidal persons are determined to die. No. So, we'll have a case scenario. 17-year-old boy brought to the emergency department. He was found unconscious. He has bleeding from the throat and arm. Cut injury noted in the neck and right arm. The exam results were out in the morning. He failed in the 12th standard board exams. The emergency care is resuscitate and stabilize. You must have to document, you must know that he is a medical legal patient. Surgical, ENT and psychiatry referral immediately. Wound sutured under anesthesia and counsel parents regarding management. What you are going to do. So in inpatient care, you must closely observe because he may try to attempt even in the hospital setup. Explain the risks to the parents. Keep all means of suicide out of reach. Benzodiazepines to relieve the short-term anxiety. Pediatrician to team with psychiatrist. Before discharge, you have to assess the risk of the individual. Give a safety management plan to be followed in the house. Parenting tips. Ask direct questions to the adolescent. How do you feel about being alive? If he feels relieved, okay. Apada tapiche. Abdina, right, he may not, he was out of impulse, he had did it. Do you regret your action? If he doesn't regret his action, he is probably having a underlying mental illness. You must understand the consequences of your action. Do you have thoughts of wanting to end your life currently or again? If you have similar thoughts in future, what will you try to do? How will you do it differently? So these are the questions you ask them directly. The safety management plan consists of the parents are told about the warning signs of suicidal attempts. These are the warning signs you have to look for in the adolescent. Adolescent to be with the family and friends most of the time. They should not get access to the means of suicide. The safety management plan to be signed by parent, teen, pediatrician and psychiatrist. This is the sample, the warning signs. The coping strategies have to be told, like what will you do if you have this thought? Whether you will control the thoughts yourself or you will get help. And whom are the contact persons or the phone numbers you are going to reach for, get help for. Then you go for the, if it is not possible, go for the professional's help, even the doctor's number or a psychiatrist's number or even a helpline. So the signature should be there of all the pediatrician, parent, psychiatrist and the teen. So important parenting tip is always you actively listen to the teen, be aware and empathetic to the teen stressors, provide a nurturing and supportive environment, encourage the adolescent for a healthy lifestyle, adequate sleep, limited use of gadgets, regular exercise, healthy eating habits, healthy friendships and family relationship. Important thing is teach them life skills, especially self-awareness, critical thinking, coping with stress, how to handle emotions and effective communication. Nurturing the relationships, personal safety, goal setting and wise use of resources. The case scenario 2, we have a 14-year-old girl with multiple superficial cuts in her forearm. What to do is, this is called non-suicidal self-injury. This NSSI behavior is defined as a deliberate destruction or alteration of body tissue without suicidal intent. Self-cutting is the most common form. This is a cry for help. The superficial cuts are, they are very superficial, not very deep. They usually have no intention of ending life. This is a feature of personality disorder. Assess thoroughly for a suicidal risk. The treatment and counseling. How to assess? By the head's interview assessment. Home environment should be asked in detail. Education and employment, eating habits, activities, drugs, sexuality, suicide and depression, safety from injury and violence. So, in this 14-year-old girl, it revealed that she was excluded from her peer group. She was not good in studies. So then she did it as a dare to be part of the peer group so that she will, I also can do something. She did not want to end life. She felt sad as she did not have friends. She was rejected from the peers. So teachers were also abusive. She was close to the parent and the religious family. She is good at drawing and in future wants to become a fashion designer. The head's interview revealed all these findings. So going to the protective factors in this particular individual, the family is stable, parental connectedness is there, it's a religious family. She's got a special talent in like drawing and ambition is also there. The risk factors are the learning disability, she has got it, corporal punishment by the teachers, it is a negative peer pressure, low self-esteem and a poor life skills. So the assessment of risk and protective factors are done. More number of risk factors in suicidal behavior implies emergency referral to the psychiatrist. So the risk of assessing the is by the universal screening for suicide, head screening, ask for suicide screen and ISPAT worm screening. Of course, we have to screen for mental disorders, for the anxiety and depression, and particularly those on antidepressants should be very closely monitored for suicidal behavior because like when they are in the early phase, they will not have the energy to do it. But once they are on drugs, once they recover, they get the energy and they will try to commit suicide. So the ask for suicide risk screening tool is you ask the patient these questions. In the past few weeks, have you wished you were dead? Yes or no? In the past few weeks, have you felt that you and your family, would you be better if you were dead? So these questions you ask and you assess the risk. So the red flag signs are this assessed by this ISPAT worm. Ideation, substance abuse, purposelessness, anxiety and agitation, a trapped feeling, hopelessness, withdrawal from family, excessive anger and rage, recklessness and mood changes. So referral, when do you refer? Adolescent suicide behavior should be referred to the psychiatrist at the earliest. Documentation is essential. In patient with imminent risk like suicidal intention with plan, ISPAT worm positive, multiple risk factors you have to refer immediately. You refer within 24 to 48 hours, suicidal intention without plan or with no or minimal risk factors. So the legal issues we go, the previously attempted suicide was a criminal offense under IPC 309, but now it is not. Attempting suicide is decriminalized. They will be considered as under severe stress by law by this National Mental Health Care Act 2017. So suicidal patient has to be registered as a medico-legal case. Healthcare professionals or hospitals should not discriminate against these mental health patients. So prevention is all pediatricians should familiarize themselves with life skills training programs that can be implemented on individual and community basis. Promote school, peer and family connectedness. Advocacy as gatekeepers for child and adolescent health, pediatricians should disseminate the guidelines to healthcare professionals, community, government and NGOs. Pediatricians should screen adolescents for protective and risk factors of suicide and suicidal behavior and conduct a mental health evaluation at annual healthcare visits. During these visits, they should discuss strategies with adolescents and parents to enhance the protective factors and the overall mental well-being of the adolescent. So in mental disorders, if you detect them, you should treat them at the earliest. So media reporting guidelines should be implemented and regulated to avoid suicide contagion, the copycat suicide. Educational and examination reforms to decrease academic stress on the students should be considered. So preventive strategies implemented at the community level and identifying vulnerable individuals may be more effective than global strategies. So here the universal prevention, we were dealing selective prevention. You partner with government NGOs, media, social networking sites, police, religious leaders and lawyers. You know that child helpline is 1098 like 1098. Tamil Nadu State Suicide Prevention Helpline is 104. I call psychosocial helpline, the Tata initiative, email based counseling. Chennai, you have the Sneha. September 10th is as World Suicide Prevention Day. These are the helplines we must know. The school support, as we have told earlier, school counselors should be there. Teachers are gatekeepers for the mental health of the adolescent. Postvention is required if suicide occurs in the school setting. So the key messages are: suicide is preventable. Adolescents should be screened for suicidal risk. Pediatricians should partner with mental health professionals, parents, teachers, adolescents to manage suicidal behavior. Essential to promote mental health facilities in schools or community for adolescent well-being. These were the references I took. So, dear pediatricians and all those who are present here, let's join hands to prevent teen suicide by changing our silence to action. Nandri, Vanakkam.
Thank you, Dr. Chenthil, for your excellent talk on the problem, which is very sensitive, suicide in adolescents. And you have told that one suicide occurs every hour. So it is a very important problem. And you have clearly told what are the early signs, how to detect it, and the history taking HEDAS, and all the screening tests also you have told clearly, and also the preventive measures which must be taken. And you have sensitized all of us on the importance of prevention. Thank you very much, sir.
May I request